Good morning. So, as we're getting ready for teaching rounds today, I wanted to run through a quick clinical explainer on our new admission. We're evaluating a really classic presentation of peptic ulcer disease, and I thought it would be helpful to walk through the case from initial triage straight through the pathophysiology, the diagnostic pitfalls we need to avoid, and our definitive management plan. By unpacking the exact mechanisms of this patient's disease, we can make sure our clinical reasoning is absolutely airtight before we step foot in his room. Let's take a look at exactly who we are treating today.
So here is the story. We've got a 58-year-old man who comes to us with a chief complaint of epigastric pain that's been steadily progressing over the last 2 months. When I interviewed him, the way he described the pain was incredibly specific. He called it a gnawing sensation, right in the upper middle abdomen. Crucially, he told me that the pain reliably worsens within an hour of eating. In fact, it's become so predictable and so uncomfortable that he's actually started skipping lunch entirely just to avoid the flare-ups. He also reported some mild associated nausea, though no vomiting. He's tried over-the-counter antacids, which he says offer a very brief, transient relief before that gnawing sensation comes right back. He completely denies any black or bloody stools.
Just to keep our approach organized, we'll break this explainer down into 4 acts: the presentation, the pathophysiology, complications and diagnosis, and finally, treatment and prevention.
All right, Act 1, the presentation. The real drivers here are his social and medication history. He takes a daily NSAID for knee osteoarthritis, a daily low-dose aspirin, and he's an active smoker who drinks in moderation. It is essentially a perfect storm for mucosal injury.
Now, how can we localize the likely source of the ulcer based purely on that history? Well, the key is his relationship with food. In a duodenal ulcer, eating food typically relieves the pain temporarily. Why? Because the pyloric sphincter closes and the food buffers the acid before it empties into the duodenum. But in a gastric ulcer, introducing food stimulates the stomach to secrete more acid directly onto the mucosal lesion, while the physical stretching of the stomach wall just further aggravates the site. Because our patient explicitly states his pain is worsened by eating, literally to the point of skipping meals, this points heavily toward a gastric ulcer rather than a duodenal one.
When we move to the physical exam, the findings are pretty subtle. But in this specific context, the negatives are far more important than the positives. On palpation, his abdomen is soft. He has just mild epigastric tenderness. What is absolutely crucial here is that there is no guarding, no rigidity, and no rebound tenderness. His vitals are completely normal, he isn't pale, and a rectal exam shows normal brown stool with 0 melena. I want to emphasize that we aren't doing this exam just to confirm he's tender. We are doing it to explicitly exclude a surgical emergency right this second. The normal vitals, the lack of rigidity, and the brown stool tell us we are not dealing with an acute perforation or a severe active GI bleed. We have time to be methodical.
Moving to Act 2, the pathophysiology deep dive. Let's step away from the bedside for a second to really understand why the stomach doesn't just digest itself on a daily basis.
You know, it's easy to think of ulceration simply as a problem of having too much acid. And sure, while rare conditions like Zollinger-Ellison syndrome do feature gastrin-secreting tumors that drive massive acid oversecretion, the vast majority of peptic ulcer disease is actually a failure of defense. It's a delicate balance. On one side, we have mucosal aggression from stomach acid and pepsin. On the other side, we have a really robust mucosal defense system. This defense relies on a thick layer of mucus and bicarbonate that neutralizes acid right at the cell surface. It relies on rich mucosal blood flow to quickly sweep away any acid that diffuses back into the tissue, and it relies on rapid epithelial repair. The master regulators that maintain all of these critical defense mechanisms are prostaglandins. Fundamentally, an ulcer forms when this defense is undermined, which allows normal or even low levels of acid to destroy the tissue.
And when that tissue is destroyed, we have to be really precise with our terminology. The distinction between an erosion and an ulcer isn't just semantics. It is defined by a strict boundary of depth. An erosion is a superficial break in the mucosal lining that's less than 5 millimeters deep. An ulcer is a break that extends deeper, strictly defined as greater than 5 millimeters. This specific depth matters because once a lesion breaches that 5 millimeter mark, it reaches down into the submucosa and the muscularis propria. That deeper tissue is exactly where the larger blood vessels live. So this 5 millimeter depth is precisely what allows an ulcer to cause massive bleeding, to perforate completely through the organ wall, or to trigger the severe scarring that leads to an obstruction.
So what is actually undermining our defenses enough to allow a 5 millimeter crater to form? Usually it's one of 2 things: Helicobacter pylori or anhydrides. Let's look at the H. pylori mechanism first. This is a spiral bacterium that has evolved a brilliant, albeit destructive way to survive the harsh acidic environment of the stomach. It produces an enzyme called urea. Urea splits the urea normally found in the stomach into ammonia. This ammonia creates a localized alkaline shield around the bacteria, totally neutralizing the acid in its immediate vicinity. Protected by this shield, the bacteria literally burrows deep into the protective mucus layer of the stomach. Once it's entrenched in there, it provokes a state of chronic, low-grade inflammation in the mucosa, which steadily degrades the local defensive barrier until the stomach's own acid ulcerates the tissue.
What's absolutely wild about this bacteria is its prevalence. About 50% of the entire global population is colonized by H. pylori. Half the planet. Yet despite this massive baseline of colonization, only 10 to 15% of infected people will actually go on to develop an ulcer. It requires a really specific interplay between the bacterial strain's virulence and the host's inflammatory response. But when ulcers do form, this bug is the primary culprit. It's responsible for roughly 80% of all duodenal ulcers and 30 to 40% of all gastric ulcers.
The other primary mechanism of defense collapse, and the one heavily implicated in our patient today, is the use of NSAIDs and aspirin. It's a huge misconception that NSAIDs cause ulcers simply by irritating the stomach lining when the physical pill makes contact. That's not it at all. The true injury is systemic. NSAIDs work by blocking the cyclooxygenase, or COX enzyme. When COX is blocked, the systemic synthesis of prostaglandins plummets. And because prostaglandins are the master maintainers of the gastric defense system, their absence causes the entire protective infrastructure to just collapse. Mucus production drops, bicarbonate secretion falls, and critical mucosal blood flow is restricted. The acid keeps arriving at the stomach wall, but the shield is gone. This is exactly why regular NSAID use carries a staggering 5 to 6 times higher odds of a gastrointestinal bleed.
Which brings us to Act 3, complications, diagnosis, and treatment. Let's navigate the clinical manifestations and, importantly, how to avoid some really common diagnostic traps.
There are 4 major life-threatening complications of peptic ulcer disease that we must constantly be vigilant for. The first and most common is bleeding, which actually makes PUD the leading cause of upper GI bleeds. This can present obviously as black, tarry melena, hematemesis, or coffee ground emesis. But it can also present silently, just as unexplained iron deficiency anemia. The second is perforation, where the ulcer erodes completely through the stomach or duodenal wall, spilling contents right into the free peritoneum. That is a surgical emergency presenting with sudden, severe pain, free air on imaging, and a rigid abdomen. The third is penetration. This is where the ulcer erodes into an adjacent solid organ. Most often you'll see a posterior duodenal ulcer penetrate straight into the pancreas. When this happens, the classic clinical clue is that the patient's pain changes character, often becoming a severe, boring ache radiating straight through to their back. Finally, the fourth is obstruction, specifically gastric outlet obstruction. This happens when edema and chronic scarring near the pylorus prevent the stomach from emptying, leading to early satiety and the vomiting of undigested food.
So to manage this disease and prevent those exact complications, we have to test accurately for H. pylori. The approved modalities for identifying active infection are the stool antigen test, the urea breath test, or direct biopsy via endoscopy utilizing a rapid urese test. But this brings us to a really critical diagnostic juncture. And I know this is a trap you frequently warn us about on rounds. Why might one of these highly sensitive active tests come back as a false negative in our patients?
Well, the answer lies in the patient's recent medication exposure. The major diagnostic trap is that active use of antibiotics, bismuth compounds, or proton pump inhibitors, PPIs, will temporarily suppress the bacterial load in the stomach. Now, it won't eradicate the infection, but it will drive the numbers low enough that the stool antigen breath test or rapid urease test will falsely read as negative. Therefore, the strict rule is that these medications must be held before testing whenever it is clinically possible. And while we're talking about testing, it's really worth noting that H. pylori serology is effectively useless for our immediate clinical decision-making. A blood test simply cannot distinguish between a current active infection and a past infection that was cleared years ago.
Now, if empirical therapy fails, or if a patient presents with alarm features like weight loss, anemia, or signs of bleeding, an upper endoscopy, an EGD, is required for a definitive diagnosis. And when GI gets the camera down there, there is a hard, unbreakable rule regarding what they do next. Because conditions like gastric adenocarcinoma or gastric lymphoma can perfectly masquerade as a benign ulcer, every single gastric ulcer must be biopsied to definitively rule out malignancy. Even if it looks completely benign to the naked eye, it gets biopsied. Conversely, duodenal ulcers essentially never harbor malignancy and therefore almost never require a biopsy of the ulcer itself. If an ulcer needs a repeat look to confirm healing, usually around 6 to 12 weeks out, it is almost always a gastric ulcer, particularly if it was larger than 2 centimeters or had initial suspicious features.
Once we test, our treatment path forks.
If they're negative for H. pylori, we treat with acid suppression, using a PPI, and we stop the offending NSAID. But if they test positive, we have to eradicate the organism. The standard of care is bismuth quadruple therapy. This is an intensive, 14-day regimen using 4 different medications, though combination pills are available. We use metronidazole and tetracycline as our dual antibiotics to clear the infection. We add bismuth, which physically coats the ulcer crater and has its own independent antibacterial properties. And finally, we include a PPI. The PPI isn't just in there for symptom relief. It actively raises the gastric pH, which allows those antibiotics to function optimally, because they actually degrade rapidly in a highly acidic environment. This is a heavy pill burden for the patient, so we must counsel them heavily. Adherence for the full 14 days absolutely dictates the success of the outcome.
Finally, Act 4, prevention, dispo, and some quick teaching pearls. Eradicating the bacteria is only half the battle. We also have to plan for long-term prevention.
Since our patient has osteoarthritis, he's likely going to need ongoing pain management, which brings up the critical topic of gastrointestinal prophylaxis. We can't just give a daily PPI to every single person who pops an ibuprofen, right? So we have strict criteria for who actually requires chemical protection. A patient warrants PPI prophylaxis if they have a history of a prior ulcer or GI bleed, plus one of 2 specific conditions. Either they are concurrently taking an antiplatelet or anticoagulant medication, or they have at least 2 of the following risk factors: age over 60, concurrent systemic steroid use, or a history of significant dyspepsia. If they meet these criteria, leaving them on a daily NSAID without a protective PPI is just an unacceptable clinical risk.
Another strategy you'll often hear proposed for high-risk patients is switching their traditional non-selective NSAID to a selective COX-2 inhibitor. Because COX-1 is primarily responsible for the baseline protective prostaglandins in the gut, targeting only COX-2 offers a clinical trade-off. A COX-2 inhibitor significantly lowers the risk of GI ulceration and bleeding. However, this comes at a real cost. It paradoxically raises the risk of adverse cardiovascular events. Therefore, we can only utilize a COX-2 inhibitor strategy in patients who have a very low baseline cardiovascular risk and who are not already taking aspirin. Given that our patient is already on a daily low-dose aspirin, switching him to a selective COX-2 inhibitor would be completely inappropriate and potentially harmful.
Also, our treatment algorithm is not considered complete just because the patient finishes their 14 days of quadruple therapy. We must definitively confirm that the H. pylori has been eradicated. A test of cure must be performed roughly 4 weeks after the completion of antibiotic therapy. And remembering our diagnostic trap from earlier, the patient's PPI must be held for 1 to 2 weeks prior to this test of cure to ensure we don't get a false negative. We can use a stool antigen, breath test, or a repeat EGD for this confirmation, but we absolutely cannot consider the case closed until eradication is fully documented.
So that brings us to our final assessment and plan for the 58-year-old man we're about to go see. We have a patient with daily NSAID and aspirin use presenting with gnawing epigastric pain that is worsened by eating, leading to a primary diagnosis of a suspected gastric ulcer. Our immediate plan is to stop his ibuprofen, start him on high-dose PPI therapy, and test his stool for H. pylori antigen today before the PPI fully suppresses the bacterial load. Given his age and presentation, we're going to consult Gastroenterology for an EGD, ensuring they biopsy the lesion to rule out malignancy. If he comes back positive for H. pylori, we will eradicate with 14 days of quadruple therapy and schedule a test of cure in 4 weeks. I'd summarize our approach with 3 high-yield pearls: always hold suppressive meds before testing, always biopsy a gastric ulcer, and always confirm the cure. Really makes you wonder, though, how many other seemingly routine daily medications are quietly dismantling our body's natural defenses right now. With that, let's head in to examine the patient.